Hello, my name's Anne-Marie Kupinski, and I'm going to take you through doing a lower extremity arterial duplex ultrasound exam. As you can see from the patient, this is how we would like to have folks position, having their hip slightly externally rotated and their knee slightly flexed. From this orientation, we can pretty much see from the common femoral artery up here, down through most of the superficial femoral. Then we'll come behind, more posterior approach here to look at the popliteal, and then continue on down the calf, and we can pretty much see everything from this view. We'll just have to turn the leg when we go and evaluate the anterior tib. But we'll start up here at the groin and orient. I usually just start with a transverse view, right pretty much as high up as I can, and try to find the saphenofemoral junction, which, let's see, let me just bring up a trackball, or the arrow, the cursor, right, yeah. Up here on the screen, you can see we have this oriented, obviously, so the patient's right is on your left, and the patient's left is on our right. We can see the common femoral vein in the center, the common femoral artery right here, and the great saphenous vein coming up here. And if I press down, I know I've got the veins where they are, as I just described. And that's really our starting point for most lower extremity evaluations. I'm just going to go into a sagittal or longitudinal view of the artery, and I'm adjusting the DGCs a little bit, because most of the time when we do vascular, we kind of like to see the lumen nice and dark, and we can throw in our color, okay? And we want to make sure we're not in the vein. I'm just slid over a little more medially to show you the vein and the appearance of the vein. Obviously, the color flow is more continuous, obviously phasic with the respiration. The artery here is a lot more pulsatile. I haven't adjusted the presets for color, and it's totally showing us the multiphasic pattern we'd expect to see in the common femoral artery. I take color off just for a second, and we take a look at the grayscale image and what we're seeing here. And obviously this is a very nice, normal subject. We have no plaque, nice thin walls. If I put the color back in again, we see good color filling. You would adjust your color PRF and your gain, because we don't want the gain up too high, and I'm going to just increase the gain for a second to show you what we don't want. We don't want this. We don't want it spilling out into the grayscale. You want to drop it right back until it's pretty much filling to the edge of the wall but not spilling out. If I put in the pulse Doppler, we want to be able to sample fairly close to the center of the blood vessel, because that's going to have the highest velocities. And we can see, again, a nice multiphasic pattern. We're pretty well aligned here to 60 degrees. I'm going to freeze it for a second. And this system is set up, it automatically seeks a peak and end diastolic velocities. And in this case, our peak velocity is 73. End diastolic velocity is just under 9, and that is, again, the common femoral artery. Now, if we saw anything other than this and did not see a multiphasic waveform, we would extend further north up into the iliac vessels and make sure that there was no disease up in the iliac vessels. But we can see here clearly on the screen, this is a nice sharp upstroke, a narrow peak, a rapid deceleration. So this is a very good upstroke here in systole, and it's telling us that that blood flow has not passed through any kind of a stenosis in any way. We see the reflected wave here telling us we're dealing with a high resistance bed, again, textbook normal. And this third component in end diastole, this antegrade flow at the end of diastole, is basically due to healthy, compliant elasticity of the vessels further central to where we're imaging. So I'm going to go back just to grayscale here, and I'm going to come down just a little bit, and I hardly move my hand at all. I basically just angled it. And now we see we're coming to a bifurcation, and that bifurcation is the bifurcation into the superficial femoral artery and the profundifemoral artery, or as that sometimes is called, the deep femoral artery. Now, because they're kind of angling a little bit in different orientations, I'm going to capture the profundifemoral artery first, and we'll want to get a Doppler signal from there as well. So we're going to look right at the origin here. And again, a multiphasic pattern, nice sharp upstroke. All right, and we see here our peak velocities are around 63. Again, usually in the peripheral artery, we want the velocities less than 150, although in most folks it's probably even less than 100. That's a ballpark criteria that we can use. But again, we're really looking at the shape of this waveform, and that's very characteristic of a nice, normal, high-resistance arterial bed. This is probably the only area that we really need to look at for the profundifemoral or deep femoral. Basically just the origin, just to look at plaque. If there was disease, perhaps in the SFA, the profundifemoral artery might be a choice for a bypass inflow site. Now we're going to come back again, and we're in the SFA now here up at the top of the screen. This is the SFA. All right, we're seeing a little bit of the vein underneath. The profunda is down here, and it angles away in a manner that we really don't see much of it. So I'm just going to look at the SFA here just for a little bit, just to point out a couple of things. And I'm trying to make it really flat, because obviously when we're at 90 degrees to the ultrasound beam, we're going to get the best image. And here again, the things we want to look for is this nice thin wall, this very smooth wall. There's no bumps, crevices, no sign of any plaque, no sign of any calcification. We can even right here kind of appreciate the intimal medial complex, which is not something we really look at in the lower extremity arteries, but it is there and we can see it. So we know we're dealing with a very healthy blood vessel, and what we want to do is really Doppler through the entire length of the vessel. So whether that's in color first to give sort of an overall scan, or if we do it in triplex with Doppler, but I'm going to look first in color, because color certainly is a good tool. And you can see I'm just sort of rocking my hand just a little bit back and forth to keep that lined up. I want to see the vessel all the way from one edge of the screen to the other. I know I'm completely dead center over that, nice and lined up with that vessel. I'm not oblique. If I kind of see this and see this sort of like kind of oval shape, I'm oblique to that vessel, and that's not really how I want to follow it down. I want to follow it like this, where I can line it right up. And obviously as you move, you're going to have to adjust yourself, adjust the position. But this is the technique that you would use to follow all the vessels, whether upper extremity, lower extremity. And let me just move that. Oh, that's not what I wanted to do. There we go. I'm just going to move the color box a little bit deeper. I don't like to make it too large, because then it'll decrease the frame rate a little bit, in some systems anyways, not in, you know, as we get deeper, it certainly, it has to travel further and listen longer and so forth, so it may drop the frame rates. So now we're getting a little bit deep here, okay? Not very far down his leg, so I'm just gonna stop for a second and get a little more gel. I don't like to put an absolute ton of gel on patients, just because that as that gel starts to dry up and the water evaporates from it, it cools them off. The patients get cold, they vasoconstrict, and then you're kind of, particularly if you're doing a venous exam, you're going to create more trouble for yourself. Now you'll probably see, let me just change the orientation of that color box for a second. You'll see various branches off of the SFA that are normally there. Now I know I'm not getting good color filling here in the SFA, but I just wanted to show you that you can see small tributaries, small branches coming in and out of the SFA. They're not important for the routine scan. However, when you have a vessel that's diseased or occluded, these can get very large and you can see them become pretty pronounced. So we're going to continue scanning down as far as we can. We're going to change the steering back. Sometimes there's enough of an angle on the vessel itself that we don't really need to angle the color box, but just sort of keep it kind of straight. And now I'm getting a little bit further, a little bit deeper, and the color is totally being my guide here because I'm getting now deep. If you look at where my hand is in relation to the knee joint, I'm really just about at the adductor canal. At about this point, that artery and vein are going to pass through the muscle and come up behind the knee. So we've really scanned the superficial femoral artery for the extent that we'd want to, and you'd want to come back and record some velocities. And we would come up, and I'll just show you again, either with the color on, and we'll need to just steer this a little, and then we'll put our Doppler. Again, we want to keep 60 degrees or less, and it's very easy in the leg to just toe heel a little bit and create a good angle. And here we are again, velocity of about 109, 108, textbook normal. We would repeat this, getting a signal, say mid SFA, and then one further down. And if you had any issues, you could just take the color off, have the machine work a little less hard, and concentrate mostly on gaining that Doppler signal. And you can see it cleared up just a little bit because we're asking it to do less. So if you come in and out of modes, remember, the machine has only so much capability. So as you add it more and more in and make it do more and more, it will sacrifice somewhere. But that's an excellent waveform. Again, high resistance, triphasic waveform. And that's exactly what we would expect to see the whole way down the leg. So we started the common femoral up here. We scanned through the superficial femoral to the point where we really started to lose it. And it started to go through and come up behind the leg. So now, without having to make the patient change their leg, we're going to come back here and find the popliteal vessels. I'm just adjusting the focus a little bit because the vessels are a little bit more superficial here. Once we're behind the knee, now what we see is the popliteal vein on top of the popliteal artery. And again, if I hold still, obviously you can see that the artery's beating, and if I compress, the vein compresses away. Again, depending upon your individual lab protocols, you can follow the popliteal artery up as much as you want. I'm really now on the lower part of his thigh, probably right about here. So I'm really picking it up just about where I left off. And again, it's nice and smooth walled. And I believe this guy coming off right here, which is the first big branch, is the anterior tib. And I followed it a little bit before we started the demonstration, so I'm pretty sure that's the anterior tib. But let's look at some color. And again, because there's a nice angle to the vessels here, I don't really have to work at adjusting the color box too much. And we see another branch down here. Who knows? One of the genicular branches, not too important to us again, but this is the area we'd want to scan. And now here for our Doppler, we'll want to give us a little more angle. 60 degrees is perfect. but less than 60 is okay. In here without having to fuss too much. I've adjusted it. Now I'm at 56 degrees. And again, multiphasic, high, sharp upstroke, narrow peak, and so forth. That's a normal Doppler signal, and we're down to about 68 centimeters per second for velocity. As we go out the arterial tree, we expect the blood to slow down. We want it to slow down, so by the time you get to the capillaries, you have good exchange. So most folks record just a representative signal from the popliteal. Coming down, we'll come back to the anterior tib in a little while. Once you see the anterior tib branch off, now where we're at is really the tibial perineal trunk. And that's a varying length. And as we come down, and I'm just going to adjust my focus a little bit in depth because we're getting just a little bit deeper, that vessel splits, and it's splitting right here. Let me put the color on, maybe that'll help show a little bit better. I'm just going to move the machine a little closer to me here. Okay, so we're up here and got the tibial perineal trunk, and if I come down real slow, now we have two vessels here, just coming and branching off, two groups of vessels. It's a little hard to appreciate. There you go, a little bit better. Now you can see the two separate arteries here. One is going to be the posterior tib, and one is going to be the perineal. And the perineal artery is going to stay deep right on top of the fibula. This is the edge of his fibula right here. The perineal vessels used to be called the fibular vessels, fibular artery, fibular vein, because of their orientation. This guy up here that's going to sit up a little higher and a little close to the edge of the tibia is going to be the posterior tibial. So you can see we followed these right on down, and you can see if I move, you know, we get some venous flow in there as well. I'm just upping the gain just a little bit because I'm actually running low of gel, but we can really appreciate here where we're at and what we see. And we can see these two vessels. So same thing, you know, down here they're getting a little smaller. I'm going to take color flow off for just a second and show you the grayscale. Now, again, these guys are small and they change their orientation a little bit, do a little bit of twisting and turning. So we want to make sure we stay on the artery and don't get fooled that we're slipping off into a vein. But there's the artery, that's the posterior tib. We'll put the color back on. And again, I'm looking up here at the top vessel. And what we want to do is probably record, and this is again going to depend on your individual protocols, but a representative signal in terms of the peak systolic velocities. And we see again this triphasic flow pattern peaking out at around 58, 57, so that's perfectly fine. Now you can follow it in grayscale, but which is fine. You do want to assess it and make sure there's no plaque or no calcification, but you can see beautiful color filling, and our subject today has wonderful anatomy. We're getting both the posterior tibial and the perineal in the same view. This may not be possible in most patients